This episode of GT the Podcast is supported by Alcon.
This content is supported by Allergan Medical Affairs.
All right. Thank you all so much for joining. We're going to have a little conversation about navigating some challenges after XEN Microstent implantation. My name is Manjool Shah. I'm on faculty at the University of Michigan Kellogg Eye Center, where, among other things, I have the joy of being the Glaucoma Fellowship Director. And I am joined by the man who needs no introduction, but we'll give you one anyway, Steve Sarkisian.
Hey, yes, Dr. Steve Sarkisian here. I'm a former professor of ophthalmology at OU, and I'm now, for the last few years, founder and CEO of Oklahoma Eye Surgeons in Oklahoma City. And like Manjool, I was a first adopter of the XEN, having had an opportunity to do the XEN outside the US before it became FDA approved. And both of us very quickly ramped up, and you know, we've done hundreds of these cases now between the two of us, probably over 1,000, and in both ab interno, ab externo. So you know, we definitely have a lot of experience between the two of us, and if there's a complication that can happen. I mean, ask anyone that does a lot of surgery, you know, how do you, you know, if they don't say they have any complications, they're not doing any surgery. You know, you have to, you know, it's just one of those things that you know, we're not building widgets in the widget factory, you know, where people are going to heal the way they're going to heal, and everything can be done absolutely perfectly with any surgery. And, you know, stuff that can happen because, you know, like people. So, and, you know, Manjool just, you know, has published this fantastic paper that about navigating challenges after XEN. Manjool, when is that coming out? And
so it should be coming out in Current Trends in Ophthalmology any day now. In fact, at the time of this podcast release, it may be available already. So check it out. Me and my co-authors are really proud of it. It's extremely comprehensive. It kind of covers it all. And, you know, I think we'll spend the next little bit of time, Steve, if it sounds good to you, breaking down a few of those topics. You know, again, we want to get at root cause. We want to think about pathophysiology, how things can be prevented, how things can be managed, and how, you know, yes, you're absolutely right. Surgery does inherently have some variables that we can or can't account for, but it doesn't mean we can't, at the end of the day, win the battle. So that being said, you know, let's jump right in. You know, one topic that definitely comes up, and you know, I would argue is more of a fear than a high frequency concern, is one of implant or bleb leaks or implant erosions. So I guess, Steve, have you run into this? I'm sure we both have, but are there any sort of risk factors or sort of preoperative considerations that make you think, you know, this is a person who I got to be extra cautious of?
Absolutely. Well, first I'll say that, you know, all these complications, you know, if I look at my first 200 cases were all ab interno. And the complications you see with ab interno, which is how it's, you know, how it was FDA approved and how the clinical trials were done, the complications are different than ab externo, whether you're doing, you know, however you do ab externo. And so I would argue that the risk of a bleb leak is certainly higher with ab externo, actually. Ab interno, it should be almost zero.
Correct. Yeah.
And, you know, and so that's, that's important. The other thing I'll say is with ab interno, as far as erosions go, almost all of my erosions happened in those patients that were in those first 50 cases, where a lot of them I was making sort of a infratemporal incision, and my all those early Zens were too nasal. That ended up eroding, or where I had a nasalized bleb, which is a whole other discussion, but can cause significant bleb dysesthesia. So, but I think the biomechanics of the eyelid going over a nasal Zen can lead to erosion, just like it does with tubes, which is why most of us with tubes try to go at 12 o'clock. The same principle applies here to prevent it going at 12 o'clock. But the patients with the very deep set eyes are going to be at higher risk for this as well with ab interno, just because of the angle of approach. And so one of the ways that I've changed my technique with ab interno is that I'll make my incision at either 5 or 7 o'clock, and point it towards 12 o'clock, so that it goes in at 12 o'clock. And the other thing you can do is when the patient is sitting up before in the pre-op area, just take a marking pen and maybe mark 12 o'clock to have a better sense of when they're lying back where 12 o'clock is. And those are a couple helpful techniques.
That's a great, that's a great point, Steve. I mean, I think a big factor is really trying to nail that 12, plus or minus a clock hour. And another thing that I've started to do more recently, and I would say I'm like 90% ab interno, but it's still nice to get that at 12 o'clock from a safety perspective and from a comfort perspective. I've started to make my my second instrument supranasally. I sit temporally, so I make it, as opposed to supratemporally, I make it supranasally. So when I infraduct the eye, I also intort the eye a little bit. So it makes it that much easier for my ab interno pass to find 12 o'clock. And in some eyes, I can almost get towards the supratemporal quadrant, which is, extra credit, quite frankly. But getting away from the lid margin is huge. I also do like to spend a little bit of time sort of optimizing the ocular surface. I think that does add value. I definitely do preoperative steroids, anti-inflammatories, obviously lubrication. And I gotta imagine just optimizing the conjunctiva, in addition to sort of assessing it preoperatively. How thin is it? How mobile is it? That's gotta pay dividends.
Oh, for sure. I mean, a number of these patients have blepharitis too. And so, considering a month of doxycycline prior to, and maybe a month before and a month after, definitely helps with wound healing as well.
Yeah. Great point. So say, Steve, you do have an exposed leaking implant. What's sort of your approach? I mean, are these eyes that, again, let's take sort of the worst case scenario where you have a exposure over or adjacent to the actual implant. Again, not common, but this is probably the more likely scenario as compared to a distal bleb leak somewhere else.
Right.
Again, because the reason you're going to get a leak is because of trauma from the needle, which is by definition going to be near the implant, no matter what. So what do you do? Do you try to aqueous suppress and antibiotics, steroids, etc., or are these eyes, going back to the OR for you?
Every single erosion of really any glaucoma drainage implant, but certainly for the Zen, needs to be, you need to fix it. And so if, I've had some of those early ones, where like 3 millimeters of the tip of the Zen that was supposed to be in the subconjunctival area it's basically just not covered. Like the Zen is all scarred, the conj is all scarred. You got 3 millimeters. Those I'll just pull them out at the slit lamp. I'll make the patient sit for 30 minutes or something, in the waiting room, and then I'll bring them back and I'll just Sidel them. 100% of the time, they're not leaking anymore. So, and then it's put them on antibiotic maybe, or if they're not leaking anymore, you can put some, I use sterile technique. I'll put in betadine and everything. And so, and then it's just like a paracentesis. So you don't really need to put them on antibiotics.
Right. Yeah.
And then I plan for plan B, which is either a second Zen in a different location, or micropulse CPC, or tube, or something. If there's just a small erosion somewhere in the middle, I'll take them back to the OR, and it depends on where it is. And I'll either take it out and put another one in, or I'll try to salvage it by doing a large conjunctival incision, and maybe doing a bit of a conj advancement. It really, every case is different.
Mm-hmm. Yeah, I think that's well said.
So how about you?
I would say there's probably a small handful of cases where I've been able to get them by aqueous suppression, antibiotics, and a little bit of time, maybe a little bit of extra care with the conjunctiva, doxycycline, lubrication, etc. These are typically little tiny leaks that are distal to the implant, as opposed to adjacent or along the body. When there's a little bit more exposure, or we got more implant, at risk there, I've certainly tried trimming a little bit if it's just the distal end. I've tried needling the implants actually to see if I can kind of needle it away from the weak area, and that's worked a small handful of times. But I'm with you, Steve. I think if we got implant exposure and it's of reasonable size, these are probably getting pulled, and I pull it at the slit lamp as well. Check the eye, sometimes put a bandage contact lens on just to belt and suspenders it, and then start making plans to optimize the eye for the next procedure, because they're going to need something. Be prepared. The other thing is, I tell my team, my trainees, certainly be prepared for this person to go from a low pressure to a spike once they start producing enough aqueous and the eye doesn't have trabecular outflow because it's had a bleb for X amount of time. So they can have a pretty acute spike, kind of like a closing cyclodialysis cleft. And
just so people know, the rate of erosion with a Zen, if you're an accomplished Zen surgeon, is like 1% or less.
It's exceedingly low.
That we do a lot of these. Do you think we should move on to a little bit about obstruction?
Yeah, I think let's talk about another. I would argue this is something that I think about a little bit more, is obstruction or occlusion of the implant. We're talking 45 microns. Again, that's a beautiful thing from a safety standpoint, but it doesn't take a lot in the wrong context to block it off. So yeah, I've certainly seen these in my own practice and referred in. If that implantation isn't right on the money, and you're a little too close to iris, or you did have some chamber shallowing after surgery and the iris got a little close to perhaps a well-placed Zen, there is that theoretical risk of just a little strand of iris finding its way there.
Have you found it's because the Zen's too long in the eye?
Often there's yeah, I'd agree. Often there's something suboptimal with the placement. Either it's a little too long, or it's a little too deep. It's a little too close to the iris. And the good news is, good gonioscopy lets us figure this out. And the device is rather simple. So you can, if you figure it out, you can often treat the problem.
So what have you done? If the tip of the Zen is, 2.5 millimeters in the eye, and your scleral tunnel, because you did ab externo, is maybe only 1.5 millimeters, and you got, 3.5, 4, you got 4 millimeters or so, you got whatever in the subconj area, but your scleral tunnel is pretty short, and it's the tip of your Zen is obstructed in a thick brown iris. What do you do? So say it's weak, it's week 1 and the pressure's 30 and you have this beautiful bleb, but you had a beautiful bleb and it's, a little lower now, but your pressure's 30 and your Zen tip is touching the iris. What do you do first? They're in the office.
I would say, in this context, granted you have a short intrascleral tract, but you got some room. If the gonio entry is good, if where you're entering the eye in the angle is relatively far away from the iris, you have a couple options. You can try to grab it ab externo through with a pair of non-tooth forceps, grab the distal end of the stent and pull it just a little bit in, towards the conjunctiva side, and that may, free it up, get it away from iris.
You do that at the slit lamp with lidocaine jelly, or just Preparacaine on pledge it?
I'll just typically just use Preparacaine, and slit lamp is usually the easiest place for this. Just have them look down. It's pretty comfortable, quite frankly. The challenge is you got to get that grab right. Too firm a grab and you'll fracture the implant. Too soft a grab and you're just not doing anything. It's nice to sort of engage the conjunctiva, translate the conjunctiva up towards the limbus, then grab the Zen and then pull back, so you're not fighting conjunctival tension when you're moving the stent. And if that doesn't work, honestly, even at a week out, a short needle track is going to be close to healing in for yourself. I bet you can get away with yagging the tip of the Zen as well. Just ab interno using a mirrored lens if you need to, and just sort of at the very least yag the iris away. And sometimes I'll actually aim at the tip of the Zen itself and kind of shake it loose, really low energy, about as low as my YAG laser will go, is typically enough to kind of shake the dust off the implant there.
This episode of GT the podcast is supported by Alcon.
So I've seen this 2 or 3 times, and they're almost invariably patients with a very thick brown iris. And I've found that 2% pilocarpine, I'll put pilocarpine in the office and make them, Q5 times 3 and make them sit for a while. And invariably, just the act of putting pilocarpine, and it's really easy if they're pseudophakic, they tolerate it really well. And just that tightening of the peripheral iris away from the angle can often free up the tip. It might still be touching it, but the very tip is no longer necessarily obstructed. And I'll do a little digital massage, and it usually opens it up pretty well. I have at least one patient on chronic pilocarpine just to solve that problem. I mean, it was amazing. The pressure went from like 50 to 10. And then
you can totally, at that point, I would say you have options. You could treat the iris there with a little argon laser to kind of do a little bit of focal iridoplasty, a little focal pilocarpine effect, if you will. You could try to truncate the Zen ab interno with YAG to again get it a little away from the iris, pull it away. You got some options at that point once you've kind of uncorked it as you did.
The key here is, if you notice it, if the pressure is high at week 1, you have to do gonioscopy.
Absolutely.
I don't do gonioscopy day 1 ever, really, but at week 1, I think, regardless of how it looks, I think it's a good idea to do gonioscopy. But if there's any issue, I think, for sure gonioscopy. I mean, you might be surprised. Some people who are aggressive eye rubbers may have rubbed it out of the eye and the pressure's high, and so
great point.
But if you do have PAS, I agree. A little YAG to the tip is a good move, and but that pilo trick I kind of just fell upon, and I found it to be
that's a great pearl. Have you had issues where you're more concerned about blood, pigment, or fibrin, something kind of more intraluminal that may be blocking things up? The example I think of is a patient with a history of a goniotomy. So there was a little bit of reflux blood in the anterior chamber, despite us trying to pressurize it. Xen went in fine, but again, that little bit of hyphema, again, very small, almost, basically a microhyphema. It's going down the path of least resistance, and I've had at least a situation or two where it's clotted off basically in the lumen. And I think fibrin in a particularly, hot post-op eye can also kind of do a similar thing. Have you ever used digital compression or even like flushing the stent and to kind of free up something like that?
So if you're going to do glaucoma surgery, there will be blood. So occasionally there will be blood, much less with the Xen than most anything else. But you're not really doing cautery with the Xen. So and so if you have a patient that's on blood thinners, or excellent example, patient has had a previous goniotomy, ab interno goniotomy, and they have hyphema during even though the goniotomy wasn't necessarily working, and that's why I had to do the Xen. It was still doing something, and you still have that open connection during that relatively hypotenuse state. When you're inserting the Xen, you can definitely have reflux blood. And so the blood can be in two places, right? So if it's in the anterior chamber and you have a clot that's occluding the Xen, you can do a little digital massage to free it up. But usually I just ramp up the steroids and invariably it's gone. If you have blood in the subconjunctival space, if you ended up with a large hematoma, I've seen obstruction there too.
Yeah, great point.
The key is I just reassure the patient. I do a little digital massage. Often it will go down, but sometimes it doesn't. And I'll just restart meds. I'll have them do digital massage at home, 3 times a day for 5-10 seconds, and I'll follow them closely, and I'll hit them hard with steroids too, like every 2 hours while awake, and follow them in a couple days, 2-3 days, and usually with that really hard-hitting steroids, almost always that will go, whether it's inside or outside the globe itself, it will improve. You just kind of have to be patient, and
yeah, absolutely. Yeah, no, you're right. We should have your face on a bumper sticker. Don't freak out. It's just glaucoma surgery.
Should it be there will be blood, or don't freak out?
There you go.
Maybe we can sell both.
Yeah, I think so.
We need to start a new business,
I think so. We have a lot of business ideas, you and me. Have you ever used TPA in this context?
I haven't had to use TPA in a long time, but TPA, it's pretty easy to get, especially if you have, hospital privileges somewhere and you can get some. And I found that to be a very good option, in the office to address that issue. I haven't had to do it in years, but
yeah, it's something that kind of happens once every couple years. Yeah, I'd agree, but it's a nice sort of trick in your back pocket if you have access to it, because I typically do 25 micrograms and 0.1 cc's, and do a little AC tap with a 30 gauge needle, and then go ahead and inject some in. And especially when I'm pretty sure, again, based on the clinical context, that it was blood or fibrin that's in there. Again, a post-goniotomy case, a little bit more inflammation. It can just open the door and do it within 30 minutes, which is pretty awesome to see. I've had blebs come back to life in front of my eyes as I'm finishing injecting that 0.1 cc's. It's pretty amazing. Occasionally I've had to revise these, but doesn't really happen too often where you're taking these eyes to the OR. Typically, again, like you said, it sort of resolves on its own. The other place where I do worry about obstruction is at the distal end, with just fibrous growth and scarring kind of occluding the distal tip. And again, often this is something we can clinically see and deal with a very simple office needling revision, where in addition to the usual needling, I'll just lop off the distal end, just a little half millimeter or something, and that can be, you know, remarkable. A few eyes where I've needled them, nothing's happening. I needle them again, nothing's happening. By lopping off the distal tip, it's just amazing. You know, you can really salvage a lot of these too.
You mean with the YAG, or
YAG, or even with the needle? You know, you're in there, you know, needling. Just turn the bevel a little bit, and I typically just get anterior, you know, superficial to the XEN, angle the needle so it's the bevel is sort of my cutting blade, and then just go push back towards the sclera and sort of pin the XEN between the bevel of the needle and the sclera, and it's just a really easy kind of cut. You know, the XEN doesn't give much resistance, so you can be really kind of nuanced and just lop off the distal tip, and you don't change your flow dynamics and Poiseuille's law, but you kind of uncork the distal tip there.
Well, that's why the old adage is really true. You know, the whole time I was speaking about XEN is make sure that the thing is as perfect as possible before you leave the OR the first time.
Yeah.
You know, just because it's in the eye and you have a bleb and, you know, it's covered, you know, you got part of it in the subconjunctival space and part of it in the anterior chamber, doesn't mean it's good. You know, don't be afraid to pull it out and do it again if you don't like where it is. Pull it out 3 times and do it again, reload it and do it again until you're happy with it. Because, and that matters. I mean, you know, I think that a lot of the reports of needling early on with the XEN were falsely high because people were just, you know, they helped people and it was good, but they were, you know, nonetheless, it was the learning curve, you know, and
Totally.
You know, if you adjust for that learning curve, you definitely, you know, you definitely see an improvement. And I promise you, my, you know, all the cases I did after the first 50 cases were, you know, a lot of these issues were significantly reduced.
Yeah, it's really amazing how much you can grow, and how much, you know, a little bit of practice and a little bit of thoughtfulness can really have, you know, huge impacts and really kind of streamline your world. It's a simple procedure, but simplicity doesn't mean ease. It just means you can think through the problems. You know, the problems are fortunately rare, but they're simple to kind of understand mechanistically, and you know, fortunately, if they're relatively simple to understand, we can just sort of work through a reasonable algorithm and kind of identify, fix, treat, still be bounded by, you know, incredible safety parameters. And I'm with you, Steve. My practice has changed. You know, I don't do trabs except for when I got to teach the fellows what a trab is. You know, this 55-year-old procedure that our grandparents used to do. You know what I mean?
Well, I think
it's remarkable.
Absolutely. I think this is a good place to close. And I think this has been a great discussion. I want to end on a kind of an encouraging note there, then, that, you know, we really had to think like plumbers, you know, and you can solve most of these problems if you just think about them and problem solve them. But really, you know, this is an excellent procedure, even with the rates of complications. I mean, this has been a transformative thing for the glaucoma community to have this surgery. And, you know, even though this is a podcast about complications, you know, these are the things we remember. We forget about the
successes. Yeah,
do beautifully. And so,
yeah.
But this has been awesome. I'm always happy to visit with you, Manjool, and to talk about this exciting technology.
Same, Steve. Good chatting with you. Hopefully we get to all do it in person real soon.
See you soon, my friend.